fourth case. She is 22-year male. He is 22-year male with history of cough and shortness of breath. CT thorax revealed left upper lobe collapse with mediastinal lymph node with a granulomatous etiology or any infections. This patient had been subjected for EBUS TBNA and endobronchial biopsy. This is the aspirate smear. The smear looks very pretty good. And let us go to the higher resolution. So at 20x, you are seeing only the necrotic background, where at 40x, we are seeing lot of necrosis in the background, which resembles caseous necrosis. They are eosinophilic and granular, with few entangled small lymphocytes and histiocytes within this necrotic area. Let us move on to one more focus. This is one more focus which shows lot of caseous necrosis in the background with occasional epithelioid histiocyte here and a lymphocyte. So let us search for any granulomas which are present in this entire lymph node looks necrotic. Let us see whether there are any viable granulomas are seen in this entire smear. This is one focus which shows a granuloma composed of aggregates of epithelioid histiocytes in a necrotic background. So one more, let us move on to one more focus. Here you can make out the epithelioid cells. They are discretely present. Here one more epithelioid cell with the collagen thread here and few lymphocytes against a necrotic background. To sum up, entire lymph node is necrotic. Few viable granulomas are seen amidst the necrosis with a suspicion of necrotizing granulomatous lymphadenitis. Now let us move on to the biopsy. So this is, as I said, it is an endobronchial biopsy. So this entire biopsy, when we see at the scanner view, there is good tissue fragments. So you can make out the bronchial wall. Then we have cartilage here. Here one more fragment of the bronchial wall. So this bronchial wall somewhat appears bluish. That means there is a cellular infiltrate within the bronchial wall. So now let us move on to higher resolution. So this is the bronchial wall. See here, it is lined by respiratory epithelium. Here also bronchial wall lined by respiratory epithelium. But the pathology is seen in the subepithelial connective tissue. This entire subepithelial connective tissue shows chronic granulation tissue with plenty of lymphocytes, then few plasma cells, and also plenty of macrophages along with fibroblasts with neovascularization. So there is a chronic granulation tissue which is causing the thickening of entire bronchial wall. Now let us see not only infiltrate, is there any granulomas within this bronchial wall. So moving on to one more focus. Again, this is a bronchial wall lined by respiratory type of epithelium. And if you focus amidst the granulation tissue, you are seeing two discrete granulomas. This is one granuloma. Let us go to the 40x. This granuloma shows aggregates of epithelioid histiocyte with a Langerhans staphyloid giant cell. Compared to previous case, see, these granulomas are surrounded by dense, they are rimmed by lymphocytes, plenty of lymphocytes in the background. Here, one more granuloma. Again, it shows similar histology with a Langerhans type of giant cell. So now we have a granuloma with Langerhans giant cell, and there is a dense chronic granulation tissue surrounding this granuloma. To establish the diagnosis of tuberculosis, we have to look for caseous necrosis. So this is an area of caseous necrosis. You can see eosinophilic granular debris, which is representing caseous necrosis. This is causing the necrosis of the entire bronchial wall along with the necrosis of the cartilage. This is the cartilage which has undergone necrosis. So this is an area which shows caseous type of necrosis. Now this is one more focus which shows similar type of necrosis. Now let us move on to one more area. This is one more focus which shows plenty of caseous necrosis. And this is the bronchial cartilage which is viable. But look at this end. Here the cartilage is eaten away by the inflammatory cells which causing necrosis of the cartilage resembling caseous necrosis. Here, one more focus where the cartilage is infiltrated by inflammatory cells. That means the entire bronchial wall is showing pathology with necrotizing granulomatous lymphadenitis, granulomatous lesion with which is suggestive of tuberculosis. Now, we have done Zn stain on these endobronchial biopsy. It has revealed acid fast bacilli, confirming the diagnosis of tuberculous pathology. And microscopically, this patient was positive for gene expert, and after 45 days, there was mycobacterium was grown on the culture.